Welcome to episode 238, Recovery, Social Justice, and the Right to Autonomy, a harm reduction framework for healing, featuring Dr. Kristin Dempsey, licensed marriage and family therapist and licensed professional clinical counselor. Make sure to subscribe to be alerted about future episodes. By Clearly Clinical, learn, grow, shine. Hello to our listeners. My name is Beth Irias, and I am really looking forward to the conversation that I'm going to have today with Dr. Kristin Dempsey. She is a licensed marriage and family therapist, as well as a licensed professional clinical counselor out of California, and her specialization is working with folks with co-occurring substance use and mental health disorders. And I am so excited to talk with her today about harm reduction, because I feel like this is one of those things that, number one, is controversial and can really get a bad rap, and there's a lot of confusion about it. But it's also something that many of us don't even really think of because we're so steeped in an abstinence-based perspective with substance use. Thank you so much for joining us, Dr. Dempsey. I'm excited for you to be here.
Yeah, thank you, Beth. I'm really excited to be here too. Thanks for the opportunity.
So why don't you tell our listeners a little bit about you and why this is such an important topic to you?
Yeah, so I've been a psychotherapist in California, as MFT and a licensed professional clinical counselor. And I have been at MFT for, I guess, over 30 years. I start thinking about like when I actually was out in the field working. So it's been a long time. And interestingly enough, when I was a young therapist, I got interested in substance use treatment, partially because of my own lived experience. I do identify as a person in recovery, which I think allowed me to approach substances and substance use and all these issues in a way that I was able to approach without fear. And I think then, and maybe to a certain degree now, there's like a fear of, oh my gosh, this is so hard, this is so difficult, and all the stigma that gets kind of packed along with working with people with substance use disorders. That's how I got into it. It's like, well, this will be great. I'll have the specialization that maybe no one else has. I'm not afraid. I'm one of them, and this will be fine. And I am so glad I made that life choice because I've developed such an interest in and respect in people who are involved in substances, processes, ways that people survive in this space where it gets labeled as addiction or a use disorder, and how people take care of themselves. And I'm really pleased that in the last 30 years I have not burned out, but I've actually become more and more interested in the work, and I've found it incredibly rewarding. So I'd love to share that.
Fantastic. Um, this topic is near and dear to my heart. Before we started recording, I was telling Kristin I have worked in the addiction recovery space for a long time, and I am intimately familiar with these concepts. But I feel like if you don't work in addiction, like quote unquote specifically, then you may not have that much exposure to these concepts. So why don't we start by some definitions? So there are things that, again, for folks who work in recovery or are in recovery may be familiar with, but for the quote unquote normies on the outside. So normies are people that do not have their own lived experience with a substance use or process disorder. Kristin, can you break down for us, like, what is harm reduction? What is an abstinence model? Let's talk about that.
Yeah. So harm reduction, and there's ways of looking at this, and I'm using my definition here from the principles of harm reduction, which is really coming from the National Harm Reduction Center based out of New York, and there's a number of different organizations that may have slightly different definitions, but I like this one because they have two definitions, and the first one is harm reduction with the small h and small r, which is a set of like practical strategies and ideas that are really intended to help reduce the negative consequences and associated with drug use, with substance use. That's helping people use safer, and that can include all kinds of things. And then there's harm reduction with the capital H and capital R, which is a social justice movement, and it's really about the belief in and the respect for the rights of people who use drugs. And that's another piece. And many people who practice harm reduction as a practice also participate in some aspects of the movement. So there's that. And then abstinence is a way of approaching substance use, which you might have already determined. That's really about, you can only be recovered. You can only really have tackled your substance use or process issue if you stop completely. So it's the whole idea of completely abstaining, absolutely no use. And that definitely works for some folks. I myself am abstinent from substances, and that's the model that I was kind of influenced by and kind of got connected with when I was in this process. But the way we like to look at it is, abstinence is one among many harm reduction strategies. Clearly, if one is abstinent, that's really reducing harm. But whereas harm reduction is a whole number of things. Sometimes you hear people say the term of like the umbrella of harm reduction includes all kinds of things. I like to think of like a basket. Work with folks. Like you have a lot of different things you can choose in this basket. Um, including abstinence, whereas abstinence is just like it's the one thing, like you quit or you don't quit. And often the philosophy of the model has typically been a binary thing of like you do or you don't. You're in or you're out. You're either clean and sober, which those terms themselves are loaded and potentially problematic, or you're not.
Thank you. And you had touched upon this idea of recovery. So when we're coming at this from an abstinence-based model, generally in our culture, in our country, pulling from 12 step. So 12 step, the originals of Alcoholic Anonymous and what that meant in terms of the structure. Again, as you said, you were in or you're out. Recovery meant I am no longer using the thing or the things. How is the term recovery different when we are looking at this more from a harm reduction perspective?
Yeah. So in a harm reduction perspective, um, the idea of like recovery or recovering, it's very much like person driven, the person being the help seeker. And so they get to choose kind of what recovery looks like for them, and that the practitioner, the person that's helping, is helping to guide that process, and having conversations and is a resource. So an important part of like harm reduction I do is really like harm reduction psychotherapy, which is kind of specifically about being a psychotherapist, which is helping people explore and look at various different aspects of their lives. And the substance use is like part of that, but that the exploration, the curiosity, working with the whole person, however they're showing up, is an important piece. So this idea then of what recovery is often created, co-created, in that process. And it often shifts and changes over times. There can be a flexibility, but really the main idea is this helping someone, you know, achieve a sense of wellness that's meaningful to them? Is this helping this person like live a life that's meaningful and vital for them? Are we moving in that direction? Kind of using that as a guide and helping them explore and honoring like their intelligence and their ability to really start to sort these things out, in a collaborative process.
When I introduced you, I used the words co occurring. For folks who are, again, kind of outside of the work of the recovery field, will you break down some of those words too about like co occurring, dual diagnosis? Speak a little bit about that because this field now is so much different than it was 30, 40 years ago. So I will pass the mic to you to handle that one and answer that question because I know there's a lot there to unpack.
There's so much there, and there's so much that I've spent my career on around this exact topic. And when I first got interested in this idea of co-occurring conditions, and we're speaking pretty much specifically of co-occurring like substance use disorders or a process disorder, and a co-occurring like mental health issue. This was, many years ago, and it was back then called dual diagnosis, with the dual being the substance use and the mental health specifically. But over time, like the definitions expanded, mainly because there's a lot of things that are co-occurring. Maybe they do or they don't necessarily meet diagnostic criteria entirely, but they're impacting someone. So there's that. We also like to use a term, I think, increasingly like co-occurring conditions, co-occurring disorders. I mean, there's different ways that the terminology shifted. But I remember, like, I'm old enough to remember back in the day, it was things like, chemically addicted, like it was just, mentally ill. I mean, just all of those pieces were used in the discussion. So that the history of the stigma is just profound. We're trying to define language that's more inclusive. And the most important thing that I bring to the whole co-occurring disorder conversation now, currently, is first of all, is that co-occurringness. the fact that people have any kind of co-occurring anything is should be the expectation and not an exception. From the work of Christine Klein and Ken Minkoff, who really pioneered this idea and very much are still promoting, very active and helping people understand that complexity is really part of the human condition, and it really shows up in all of this and all the work that we're doing here. Because on the one hand, we're kind of really trying to understand all the best tools to work with someone and various interventions, and yet this ability to sit and listen and be careful and to spend lots of time developing a relationship from which we can truly understand the unique way that individuals show up, and to assess on the very specific ways that co-occurringness can manifest itself, and like where someone wants to start, and of all the things I have going on for my life, like what's the most problematic for me, what has the most interest for me, being able to hold all that and to determine like where to start in collaboration. Like that's the work. It's a very process oriented way of working, and to some degree a fluid way of working as well.
That is in stark contrast to the origin story of Alcoholics Anonymous and Al Anon, which was, for listeners who aren't familiar with it, Al Anon is the complementary program for the loved ones of someone at that point who are struggling with specifically with an alcohol use condition. That then has expanded now into Narcotics Anonymous and Nar-Anon, and then so many different versions within 12-step. That language is so much different than 12-step, which I think for folks who haven't been in a 12-step meeting before, the self-identification of I am an addict. Can you speak a little bit about the different terminology between the adherent 12-step and the more flexible harm reduction approach?
Yeah, so 12 step is interesting in lots of ways because there is this sense of like the importance of identifying as, as an addict, or the loved one of someone who's an addict, and this is kind of the program I'm involved in, and I participate in this program. The program is very structured, and there's a way of doing it. On the one hand, like I really respect pieces of that just because it provides so many people with something that can be in community, like a helpful path if that's what they're ready for. And then with the harm reduction model, it's like you may use those terms to describe yourself, but you may not, and that's all okay. Everything is is important. Everything's useful. However, you're relating to this substance, like that's that's what we want to explore. But what's more important, I think, here is that in the harm reduction approach, the relationship and helping someone have a relationship, with themselves, with each other, and in that relationship to continue to explore the curiosity, the openness, the process, like that's what's driving it. Whereas in 12 step, it's much more about here's a structure, here's a program, and you can participate in this. And that if you follow these steps, like it gives you a guide for how to potentially, experience some relief, or to gain some sense of agency over what it is that's really giving you pain. One thing that's interesting about 12 step, though, I just have to say, is that functionally is it ends up functioning in a harm reduction manner, because I can go to a meeting, having drank, unless I'm being terribly disruptive. Typically I'd be allowed to stay, and that I can come back tomorrow even if I drink. So there is one kind of interesting aspect of 12 step, is that it does ultimately function in a harm reduction way, which I think a lot of programs that really value abstinence ultimately do, because it's just kind of the nature of this process. It's the nature of the relationship we have to these things, whether it's a process or whether it's a chemical, that it's very, very difficult to just stop, and just stop the first time. And what would we do if it was just like you can't ever come back, or you really do have to stay away for a certain time? I mean, there would just be basically like no treatment, because they're this going back and forth. It's always happening, and I'm going to take this from a harm reduction perspective. That is an incredible place of learning. Like anytime someone, what might be called relapse, but we might call recurrence or return to use or what have you, it's not a place of shame. Unfortunately, in a lot of models, that's like, oh, I failed. And so I talk about this in my book, and I picked this up somewhere in my life. Some great person gave me this, but failure stands for FAIL instead of a failure. So the FAIL is a first attempt in learning. Anytime someone does, have a slip, so to speak, or there's some sort of setback, it's like, what can we learn from this? Like, we can expect this. How can we work with it? So it's something that we can build on. We do like behavior chaining, that kind of thing, to figure out like what's going on, what was happening beforehand, what was the result of this. So everything can be a part of learning, and it's about learning and behaving differently based on the learning, as opposed to a shame-driven approach of you failed, you better do better, which is so re-traumatizing for so many people.
When we look at these various models, not just within the recovery community, but within mental health. I mean, alphabet soup, it more acronyms are added on the daily, and we're always considering how well do they work. One of the things that I've told clients is, and this is like kind of where I nerd out in like the feedback informed treatment world of like, they work, so, the ones that have been really well studied, they work for some people some of the time. And that's really what the research shows. Can you break that down? Because 20, 25 years ago, the conversation that we're having right now like was in its infancy, and recovery did not exist unless it was all or nothing. How do they stack up when we compare an abstinence-based model to a harm reduction model in substance and process addictions?
Yeah. So what's so helpful, I think, in this is just being process oriented and being able to be really flexible. So with abstinence models, like folks are able to, for lack of a better word, I'm going to say folks are able to tolerate being in an abstinence model, or who maybe it fits. Like, I'm ready. I'm ready
Yep.
for this. I'm ready for the structure. I need it. I want it. I love it. Or maybe I don't always love it, but I'm willing to work with it. It's helpful for me. Like that. That's a beautiful thing, and we need those programs. And of course, we know that they do great work, and that people graduate. I think in terms of like the amount of folks who are able to stay kind of in recovery, which is more or less abstinent, because that's usually what the expectation is often, up in like 60, 70%, over the years of research that I've looked at. And that, like a lot of, disorders or conditions that we're dealing with that are chronic in nature, such as like asthma or diabetes, like people will be able to stay absent for a while. There might be like a recurrence, but that folks often are able to kind of get back on track. Not everyone, but a lot of folks. So even with that great abstinence model, I mean, we still see like afterwards, potentially some recurrence. The thing that's like really incredible about harm reduction is that for all the folks who couldn't quite get to that abstinence recovery door for many number of reasons, sometimes just because of lack of access, but many times it's like lack of readiness, or for other competing issues. This is a place to help folks get started wherever they're at. So when I teach my students like their mandatory like substance use treatment class that they need for a graduate program, the thing I tell them, and this is from like William Miller, who's one of the developers of motivational interviewing, and others, but thinking of Bill right now in particular, is the importance of, really wherever you are, whatever conversation you're having with someone, you are doing substance use treatment potentially. So it's not just in these places that someone's able to get like the care and the special abstinence treatment centers. When you're a school counselor and you're talking to that young person who's coming in who's like smoking cannabis between classes, when you're a career counselor and you're working with someone who's really having a hard time getting a job, what have you, like those conversations in ways that are curious and open and help me understand, like that impacts people's behaviors. Like when someone is having a conversation that's not judgmental but curious, and what else, like what are you getting from this, what else could we do to build out your toolbox, just having that conversation is helping to mitigate further use potentially. So this is a place where we can have folks get interested. Some folks in the harm reduction world and having these conversations will choose to maybe go into an abstinence path later on, but many will not. Many people moderate their use and regulate their use. So if we're looking for a world where everyone's completely abstinent, Um, I don't think we'll ever get that for one thing. I just don't think it's even possible. But if we're looking for a place where you know, people can be using or doing what they need or want to do to take care of themselves, which could include substances or processes, especially with the process stuff, right? Because there's a lot of things we do, like using screens, for instance, that could very easily slip over into problematic use, but we're not going to never use a screen. But how can we be in this world where we can have all of this, but have it done in a way that isn't harmful. That's really reducing harm, or people have an awareness and feel comfortable having conversations about it in ways that are non-shaming and non-punishing.
So, if in abstinence based, we're saying, I've maintained my abstinence and looking at 12 steps specifically for X number of days, X number of months, X number of years, I have chips to celebrate this. I had my 17th birthday, for example, and we had a cake at meeting. That is so concrete. When we're looking at it through a harm reduction perspective, it sounds like it becomes much more individualized to that person's wholeness of this substance or my social media use or uh, my compulsive sexual behavior, let's say, just to pull in these other ideas of what are termed process addiction. So it's not substances, it's not chemicals, quote unquote. It's like this thing I do and I can't stop doing it, whether that's shopping or whatever it is. It sounds like then it becomes much more defined on that individual, not this all or nothing, and much more customized, and as the word you've used is flexible for that person and what they're seeking. So really it almost becomes self-defined.
Absolutely. And I like to think about, and I often bring this in because people don't know what they don't know sometimes. Like, I just don't know. Like, I want things to change, but I'm not sure what or how. But I often will bring in things um, like the dimensions of wellness, which includes like let's look at the different places in your life. Like how are you doing like academic or occupationally, spiritually, like medically, physically, health wise, all these different pieces in terms of finances and all the kind of different domains of one's life and wellness, and start to think about like how are you experiencing satisfaction here or want to do like how could shifting um, your relationship with anything kind of move you toward that kind of more satisfaction or way. And of course, I use a lot of values. I do use acceptance and commitment therapy. Often, once someone's engaged and they're really kind of interested in the work, or they can see a space for them, that's I often use ACT. I usually typically start off with motivational interviewing because it's just the most wonderful way to have and encourage folks to be in the room. So MI's increasingly motivational interviewing is increasingly being combined with other types of approaches to help folks. Like once they have a place of direction where they'd like to start, and they're able to determine some goals. Sometimes other types of approaches could be really any type of therapeutic approach, but I tend to use more the mindfulness based cognitive behavioral therapies.
I want to jump quickly over to a different lane and then jump back to this one. As you and I sit here having this conversation, we have more people who qualify for classification for an addictive disorder than in really measured history in the United States. Can you speak to that a little bit? Because I think for many of us, it's like we have this image in our minds of like, that person is an addict, and then it's like, here's all the stuff that means. Um, and someone who has a really severe substance use disorder may have some of those things and then not, so then we get into that category of like the functioning alcoholic, or there's like the mom wine culture. Can you speak a little bit about like how prevalent are substance use disorders in the United States? Because I think that's like an important consideration, because it's like, oh, that's those people. And it's like, ooh, let's number one, back away from that language, but also like, actually, can you correct, I think, some of the myths about how often people really have what we would consider a problematic relationship with a substance?
Yeah, and I think from the most recent data I have from the Substance Abuse and Mental Health Services Administration, SAMHSA, who often does these like big data, large household surveys, we're talking like close to 50 million people would actually classify for a substance use disorder in any given year, which is a lot of people. It's about it's over 17%. So it's probably, who knows, right? It's probably even closer to 20%, to be honest. But, think about folks who are missed and such. But of that, we have, more than 1 in 6 people then who are using in a way that's considered problematic. And again, I think they're really looking at what we're exploring in terms of substance use disorders, which generally includes chemicals and gambling. We have other process behaviors that haven't quite met the diagnostic criteria yet, although I anticipate some of them will. I anticipate gaming will very soon because it's already in the ICD, and so it's very, very prevalent. So that's just like folks with substance use disorders. That means, we're on a continuum from like mild, moderate to severe. That doesn't include necessarily folks who have like risky use, right? Which might not actually be meeting any kind of diagnostic criteria, at least not yet. So there's a lot of folks who end up in that category. So I've seen data as high as estimating maybe half the population, half the adult population are involved either with the SUD or some sort of risky use at times. And I think another important thing to remember is, of course, we're not just talking about the individuals, but they're parts of families and communities. And so there's a lot of people impacted. And it's an interesting thing I do because I teach, and I teach substance use treatment. And I always do this exercise. And I know a lot of professors do this exercise if they teach this course, but it's such a great exercise, which I call the abstinence paper, where I have someone give up something that they do, and it doesn't have to be anything they feel like they're addicted to, such as something that you might feel so habitual for a couple of weeks, and I have them write about it. And the papers are always so insightful. And you really see folks absolutely coming to this place of, wow, I have a really different perspective around all of this now because I myself went through this and had to try to stop something. And then also having taught classes, and I'm out, promoting, a book on harm reduction and motivational interviewing. I'm in different places. I'm always so touched by like how many people come up and talk to me, like before breaks, afterwards, just about their own experiences. So there's just so many people out there just so eager to talk, and that are talking to me about themselves or their families. But yeah, the prevalence is profound and powerful. So everyone really does have a role in this. I think everyone is clinically has a has experience with substance use, in probably more significant ways than they can even imagine. Right. So it's more about like, am I addressing it? Am I open and aware of like how much is it showing up in my practice?
Thank you. That was a thought that I was having just even at assessment. It's like, oh, well, you only drink 2 glasses of wine in a month. And we'd be like, okay, there's no issue there. Um, but if we dig in to find out, as you said, kind of like the risky behaviors where it's like, oh, yeah, but sometimes I go to a wine festival, then I drive home. So on average, it's 2 times per month. But, if it's that summer wine festival, then like all bets are off. And I appreciate you making that point because we can't really do anything about it clinically if we don't even recognize that it's happening because we've made an assumption of like, oh, this person, doesn't fit again that picture of what I have in my mind of what someone who has a really severe substance problem. They don't fit that. So it's probably not something we should be talking about clinically. Let's talk about the controversy with harm reduction. You've touched on it a little bit. Why this conversation now? Can it give our listeners a little bit more history about this model and why for some folks it's like, oh, dirty words.
Yeah, yeah. So yeah, harm reduction right now, because it's been really let me put this. It really has gotten a bad name, probably because mostly of media promotion right now, and I think that's because mainly we've had policy that has either been misrepresented or it's hasn't always been applied in ways that have really been the most effective. So I'll just kind of roll back and speak a little bit about why harm reduction and why you're even hearing about it, because of the nature of some substances that folks are using. And specifically, we're talking, a lot about, say, like opiates and opioids, like synthetic opiates. And opioids include things like fentanyl, which many people, of course, have heard about, and the nature of the substances. And in some places, we definitely see many more folks using these substances out in public. And I think it's being used many places, but in some places more in public because we don't have housing or other resources for folks to be in. So it's very prominent in many communities. It's like, just stop this, right? Just get this taken care of. We don't like to see this behavior. It's really, and it is can be very hard to see. It can be very hard to see people like on the streets struggling, absolutely, without proper shelter, without proper food, and the substances are like it's a part of a lot bigger picture of trauma for sure. And so one of the things we know is like, how do we engage folks because are not necessarily like eager to stop. Um, and I think that's where we get into this thing of like, well, we have these treatment programs, but they're abstinence programs. They're programs you have to participate in a particular way that can be really hard for folks to participate in. And one of the things we know about harm reduction is that it's really the most helpful probably for the people who obviously it's just most helpful, but it's definitely the most needed for people who are the most marginalized and minoritized and least resourced in our communities. Because if we're on the streets and I have something that I'm using where it's really painful to stop using because the nature of the withdrawal, it makes it very, very hard to be in an abstinence program potentially. Like just the thought of it, the thought of like kicking a drug, or I may or may not have access to medication that would help me. I may have some really strict kind of living guidelines that may just feel really intolerable. It's relatively easy to say, you know what, not that. But the harm reduction is important because what we're trying to do is be on the streets with folks and really work with people who are traumatized in terms of building relationship, building connection, gradually reducing harm, helping them stay alive while they're on the streets. And that could include things like giving folks, like proper needles to use, like needle exchange, having safe shooting sites, or those types of things. But ultimately, the idea is we can gradually expand the types of things that people are offered. Some folks might go into treatment sooner than others. Some folks may never go into treatment, but we're out there trying to help keep folks alive. I mean, that's part of the philosophy. And so there's a couple things then that kind of come into play here. One is just that there are folks who do not believe in like the harm reduction with the capital H and capital R, who don't think that folks have a right to use at all. And so like, why would you even do that? People die on our streets as a consequence, abuse, right? Like a real non-compassionate, kind of cruel kind of approach to this. And then folks who want to engage in this more compassionate kind of care, like let's help people stay alive, help build community resources that folks aren't in as much pain, where we're really helping to sweeten the pot of like a different type of lifestyle because people have places to live, people have food, people have resources. Like that takes a lot of resource. Harm reduction works, but it does take more time and energy. You can't just throw something at it like a particular program. Like we're going to go and do outreach, and then that's all you do. You have to follow up with like continued outreach. You have to follow up with some resources and kind of build this in over time. And in some of the places where it's been like, well, this harm reduction doesn't work. See, was done over maybe a year and a half. Some programs that were going to go out to work on the streets with folks to help engage them didn't even have their contract signed before like the first review of the method, and that there's only maybe a one or two types of interventions provided, like engagement interventions, like getting to talk to people in parks, which is a great intervention, but you need to have a whole continuum of care, not just stop at the engagement. So that's why I think harm reduction has gotten that kind of bad name. But this is really, in general, harm reduction. It is a real cry for like our body autonomy. And we have this in a lot of places right now. And this is going to be a continued struggle, I think, in our culture for a while, whether it's like our ability to have access to things like gender affirming care, our ability to support our own reproductive choices. Harm reduction is kind of being pulled into that as well in terms of how I manage my substance use.
You've mentioned someone's right to use substances. Can you speak a little bit more about that, kind of in this realm of body autonomy, of personal choice?
Hmm.
Again, because it is so different than I grew up in the DARE program.
Right.
Um, so it's very different than past perspectives.
The DARE program, which consistently has been proven one of those things that just doesn't work to act. prevent kids from using substances, but it did scare, right? It did provide the scare, and
Good slogans, you know.
yeah, right. And by the way, there's a lot I'm speaking about today too. I want to give some proper reference here, just because it's such a great resource, and that is the harm reduction psychotherapy kind of book and resource by Pat Denning and Jeannie Little, who just came out the second edition, which is a fantastic resource for like all these things I'm talking about. So for like one great psychotherapy book on this, I would really recommend their book. And I will speak a little bit to this idea of, well, people have a right to use substances, like, because that is something in our culture where it's just been so stigmatized. Like, no, it's wrong. How could anybody have a right to do that? And there's a whole number of reasons, like why people use, and sometimes people just like to use. People just like to party, so to speak, right? There's just people who just like to use. There's that piece, and that includes many of us, including many people listening potentially, and we all have different substances maybe that we like. And there's a whole number of other people who might be using for that reason to recreate, let's say. But there are lots and lots of people who use substances as well because it's a way of managing. It's a way of managing grief and loss and trauma. So I think harm reduction is also an aspect of providing trauma informed care, because so many people who have a history of um, adverse child experiences, generational trauma, community based and level of traumas, people surviving things like aspects of our climate crisis and catastrophes. Like, people are using substances sometimes to take care of themselves, and there are folks who survive because they have used substances. And again, that's not the only thing we want in someone's trauma toolkit. Right? We want to be able to expand that toolkit so there are lots of other things people can use to manage loss and trauma and grief. But that's a really important thing to think about. And I also think about, like, even folks who are in our community who might be, outside using, that we can see very publicly, right? It's like, certainly there might be some folks who are out there recreating, right? That could be the case. But there are so many people who are using some of these medications specifically, around pain, pain management. Sometimes it would start off as physical pain, but there's a lot of emotional pain that's being managed through substances as well. So I'd like to really try to think of it from that particular kind of compassionate place that, we've created, a community, a culture, a society where substances have been like really central for people. And to ban them or to take them away or to find, to shame in such particular ways is really, again, kind of moving away from that compassion of what it's like to live in our community right now. So if we're really thinking about this holistically, there's a lot of other things we need to be doing besides just treatment, like providing housing and clean water and safety and, all kinds of other stuff. But that's a couple of main reasons I think about, like, why people use.
Thank you. One of the considerations that comes to mind if we are speaking about a person who is struggling with having access to food and clean water and secure housing and all of that, how does access to harm reduction based treatment compare to access to 12 step?
So that's a really interesting question, because I think in many ways, that is certainly one of the successes of 12 step. Is it's everywhere.
Everywhere.
It's
It's everywhere.
everywhere. And one of the things that folks really love about 12 step too, if we look at kind of the research and some outcomes, like 12 step can have actually some pretty good outcomes. But it's about fellowship. It's about being in community. That's the thing that people are connecting to more than anything. So my idea around this is that we can do the same thing with harm reduction. It can be everywhere too, not necessarily in special harm reduction programs, although that's wonderful when we have like harm reduction therapy centers and specialized programs, and maybe even like mobile teams that go out on the streets and such. But each of us, in all the work that we do, we can make choices about, are we going to have these conversations, and do we become maybe not total specialists, like that's something I specialize in, but what ways can we in our therapy practices day to day provide harm reduction? And so are we doing it in schools and colleges and in workplaces, all within the context of how we function? So we know we have larger rules and larger systems that constrain some of the work that we do, but can we try to find places to have more flexibility? I think that's the way that we really start to scale up production in so many ways.
For listeners who are aware of all of the 12-step options in so many communities, I hesitate to say every, but like so many communities, what are some of the non abstinence based substance treatment recovery options that are free and low cost, that are community based? And I ask that question because I remember working in the LA area and going like, wait, what? That's available? Wait, what? There's one that's Buddhist based, and like learning about this because I think that's part of it is like we're just so steeped in 12 step and have been for so many years that it's like there are these other really cool things happening, but if we don't even know they're out there, we can't find them.
Right, absolutely. And so I'm in the San Francisco Bay Area where we have access to things like the Harm Reduction Therapy Center, which is fantastic and is a great resource for lots of different local, sometimes less local resources, including groups and therapy and such. But there's some other great resources if you do go to the Harm Reduction coalition, but the place I had just given the quote to, and I can certainly make sure that's in our notes, that can actually help you find resources all throughout the U.S. just that are very specific to people thinking about like harm reduction and having specific harm reduction groups. And then there's other types of community support groups that someone could use for whatever recovery they're putting together that you're mentioning here, including things like refuge recovery, which is like a Buddhist based kind of recovery program. And some of these programs might be, you might have more like an abstinence base, as well, but there's some flexibility sometimes in the model in terms of like how someone comes to it. So like there's like Dharma recovery, but there's also some that are very cognitive behavioral based, like smart recovery or life ring or saver sobriety. Like some of these uh, organizations people like as well because they're more about like rap groups and learning using tools, and some folks find that just so much more accessible than the structure of 12 step, which historically it's almost 100 years old now, was really based on more like being at church and like a church model and using terminology like the words of like the Christian God and such that many folks just do not connect with. So there definitely are other resources out there.
Thank you. I appreciate that. For me, working in this field, I think that's been one of the considerations that I've seen, and I know it's common where it's like that model, for whatever reason, just doesn't work with me. I don't have enough time for that, or like, what if I'm doing really well and I don't want to go to meetings anymore? How does that community-based program view that versus another one viewing it in very different terms? So to dive in a little bit to the nitty gritty, when it comes to working in a more trauma informed harm reduction perspective with a client, what does that look like? Like you mentioned motivational interviewing to kind of, I guess, bring in. And we have some really wonderful content with a number of motivational interviewing experts. So I definitely recommend take a look at those other interviews that we've done as well. But like within that space, because typically any of us, when we're attempting a behavior change, we're like, I'm going to go to the gym 3 times a week. And then a week passes and it's like, I didn't go to the gym. And that inspires so much shame. And we feel bad about ourselves. It's like, why is this so hard? What does harm reduction look like in the room with a client when we're trying to break that cycle of, I tried to do the thing, I didn't do the thing, and I am awful?
Right, right. So part of what we're doing is really leveraging the relationship and helping people talk and talk as much as possible. Because, like, when folks are talking, again, we're using motivational interviewing here to get started to be engaged, that we can start to listen for. The places where there's some willingness or openness to change, and that's a really important place to start. So, a couple things I'll say about this, and that I think are essential. One is that the relationship is really critical. So it's so much more important that I am building relationship kind of primarily, and the assessment is like secondary, like assessment forms and filling out a lot of intakes and those kinds of things. Like we can get to that. I mean, but that should be it's kind of second tier. The most important thing is that there's this curiosity, this openness, this safety, this comfort that we're developing with folks. Because people need to be psychologically safe before they can really get into their stuff and before they can even be willing to open up and think about, like, where would I even start? Now, another thing that's important here, which is not easy, and this is the hardest part about motivational interviewing, I think, is keeping myself out of the way. So I can get really into like wanting to have a particular outcome. I can get really into like this session, at the end of this session, I want them to be working on something. Okay, they can choose it, but I want them to choose something. And I have to notice that and to put that aside. I can certainly be curious with them, during the session, like, is there anything they're thinking about? But to be so process oriented. Like, if they're not ready, they're not ready. I really can't push them to a place. And for me to reframe all of this, that this relationship, this being together, this being curious, this, being reflective, this is the work. Because what we're trying to do is to help folks feel safe. And even if there isn't a real specific, like, solid outcome after a first couple of sessions, but they're coming back, like, that engagement is so important. That engagement is building hope, is building energy, is building momentum, is building, more agency. We're helping folks go down a different path. That's really critical. I was doing a training. It was had motivational interviewing kind of nature to it. It was actually a crisis training several months ago, and I had someone in my training, a clinician, say something like, we have people in our community, this is a rural community, who are afraid of therapy, and I have to tell people, like, you can't just, like, run up to them, and get them to do stuff. It's like my dog. People run up to my dog and they run up to her and she freaks out and runs away. Just sit there and be just calm. Dog will come to you, like, if I can just kind of be calm and be safe, like, they'll kind of wander over. And since then, I was explaining this to someone else, and they're like, "Yeah, just have to let them, like, smell your hand." And so I'm often doing this thing, like, clinically, like, how to let somebody kind of sniff my hand, like, to know, like, I'm okay. And that sounds like a little bit weird or extreme, but actually, I think so many folks have been so traumatized, and even people who don't look traumatized necessarily, even folks who are functioning and, like, have high level jobs or what have you, the trauma of the shame or the anticipated shame is so intense, like, creating the safety, and using all the spirit of MI, being super collaborative, finding ways to, like, reduce their suffering through compassion, help support autonomy, being really accepting of where someone is. Like, this isn't where I necessarily want to be, and that's me. This is and just this is what their reality is, and I may want them to come to a goal right now, but they're not ready for that. Like, all of that early work is so 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 critical, because once folks start to get attached, kind of classic kind of therapy kinds of pieces here, and start to feel safe, then it becomes so much easier to be able to say, hey, I'm wondering about, like, if you're thinking of doing something for yourself, like, what might that look like? If you're thinking of just exploring some aspect of your relationship to alcohol, let's say, what could that potentially look like? And I find with that gentle, shifting toward, like, steps, but very intentional, listening for change talk, listening for the reasons, the needs, the things people feel they can do, the things they have done, the things they want to do. If I start to listen linguistically to that and really respond to it, we start to get there. And all the steps are important steps. Even the tiniest baby step is actually really a critical piece. So I often will tell folks, like, harm reduction is what we're trying to do here to really promote someone's wellness, and the motivational interviewing is the how we do it. And just, it's so consistent with trauma informed care. All the pieces of being trustworthy and predictable and safe, collaborative and inclusive. Um, yeah. Oh, another thing I'll just add to this as well. So I've mentioned a little bit about assessment, and there's an important concept that Denning and Little bring up in their harm reduction psychotherapy book, which I think is also helpful in this kind of conversation, is that assessment is treatment. Like, just by being in a relationship, being curious with people, exploring, like, that does impact how much someone uses a lot of times. It does help change their own relationship to substances. I'm more likely to think about it. We're having some of these conversations about it. Um, and again, however that changes for someone, is highly individualized, but that we're really doing something. It's something really important when we're having these conversations and just wondering about help me understand, what's this like for you? What does this do for you? I'm always very much into like, what's the function for you? And it's curious about other things you have that help you also obtain this particular experience. If you're using this to help reduce anxiety or to manage depression or to feel more comfortable socially, what else is in your toolbox that helps you with that? And then later on, like, is there anything else you'd like to keep adding to your toolbox?
When you're working with clients from this stance, do you find that you're integrating little nuggets, if you will, of psychoeducation and saying, like, kind of this is what change looks like? We think of change being this really big jump, and I did the thing and then I stopped doing the thing. But the research, it doesn't reflect that. Do you bring that element in of psychoeducation?
I do, I do. I really try to reassure, and um, I try to reinforce and support every little change that seems to have been beneficial for someone. So if there's a cutting back or a curiosity or trying something, and it's not even so much like, oh, I'm so glad they're doing this. Like I really approve. I mean, I personally might be really happy for that they do that, but just like I want them to feel empowered. I want them to start feeling agency. I want them to be noticed. It's like catching people being good. Like little kids, it's like shaping behavior. And I do try to do that. And I've noticed that, many people really resonate with that. They want to be acknowledged, especially because so many folks I work with have this history of that's not good enough, or, you're failed here, or can't you see you're blowing it? Like to be able to be very much cheered for the small steps. This is really powerful.
When we are working with a client from a harm reduction perspective, and again, really kind of aren't we always, regardless of whether we work in recovery or not, um, and it and that quote unquote harm reduction, the harm is not being reduced with this particular client. What's in our toolbox then when we've tried doing those things? We've brought them in, we've identified some of their motivations for potentially changing this behavior. We've come up with alternative behaviors, and like we've done all the things on the whiteboard, and we keep checking it off. And then you're like, oh, where do you go with that when it feels like there's a harm reduction roadblock?
Yeah. So I'll often, certainly bring it back to the person and just stay calm. Stay calm in myself to not try to like become like overly directive in a way that probably is really definitely not going to help. And uh, typically, typically what I think though is like if that's pretty rare, because usually it's like if they're coming to and I'm able to present for them or able to kind of come up and brainstorm like different ways of doing something, usually something connects. And actually, just the fact that they've come back and they're sitting with me and they're talking about it, we're still doing the harm reduction work. And so maybe I even just get curious in like a very process oriented way, like what's happening with us now? Like you keep connecting. There's something here that seems to be important or potentially, but you help me understand that. I just get really curious about what's bringing them back and what they hope for. I mean, I suppose we always can have these situations, right? And there's always that piece about like when to become more directive, like if someone's like going to harm themselves or somebody else. And I typically find, and certainly that can happen, or someone is is kind of imminently, just like so gravely disabled, like they're maybe something that they need to be hospitalized for, and again, I really try to work with someone to have that be like a voluntary process, as opposed to involuntary. But generally, it doesn't really get there with folks who are willing to come in and talk. It's different, I think, for street teams. Street teams have to make kind of a different decision sometimes. And there's different laws in different communities now about like when someone can be considered gravely disabled. California, this has shifted some to include substances now. So that's kind of a different piece. But I find that that's a rarity, just because the fact that someone's coming in is showing like some level of willingness, some level of like wanting to do another thing, and maybe we do a little bit of what we sometimes call like act like the creative hopelessness of like, let's try to think of all the things you've tried and kind of really think about what else.
Thank you. As we're talking about this, I have like so many more questions, and we could just keep going. And I'm also mindful, like, oh, the hour's coming to a close. I know my takeaways from this conversation are really around a person-centered approach, around compassion, and the other thing I'm hearing so much of is around patience, and awareness of power. I had a beautiful interview with Stephen Andrew, and he talked about this idea that when we tell somebody else what to do, whether it's like this kind of well-meaning advice clinically, or it's like a legit, like, this is what you're going to do today, we have taken away their autonomy, and that ceases to become trauma informed, because that is what trauma is. Like, trauma is when we do not have the choice to control what's happening to us. And I love that perspective that you're providing here, because I think it really is, and I know I'm pulling from MI language here, but it's really about a stance less than an intervention. It's about a stance. And I think it is in major contrast to where we were as a field a number of decades ago, to be shifting this stance with more awareness and openness. So thank you for coming in and talking about that, but also providing so many helpful resources. Again, for our listeners, we've had the sincere pleasure today of hearing from Dr. Kristin Dempsey. Kristin, for our listeners, what are some other resources that you mentioned? SAMHSA, you mentioned some great books. What are some other things that you think are really critical for people to help them build out this better understanding and more intimate relationship with harm reduction?
Yeah, I think it's really helpful to know all about motivational interviewing in many ways. And so the most recent edition of motivational interviewing, helping people change and grow, came out in August of 2023. It's the fourth edition. That is really worth checking out. And also with SAMHSA, SAMHSA has treatment improvement protocols. They're called TIPS. And if you go to SAMHSA, samhsa.gov, you can go into their search engine and you can actually look up their tips. And there's tip 35, which is on substance use disorder and motivational interviewing. And it's a great little book. I mean, it's actually a book on how to use the MI skills just in a way I've just been discussing, and it's free. And then there's also tip 57, which is on trauma-informed care, SAMHSA as well. It's also just a wonderful book. I mean, these books SAMHSA puts together, they bring together experts in the field to produce them. So they're really high quality and they can link you to other resources. So I like those because they are free. And in addition to the Harm Reduction Psychotherapy book by Pat Denning and Jeannie Little, I also have a workbook out as well, the Harm Reduction Workbook for Addiction, that just came out in January of 2024, a new Harbinger. And that's something you could use, and people are using it to help with journaling, either in or out of sessions. Some group work folks are using it for. So included some of those materials in this discussion as well today. So those are definitely some great resources.
Fantastic. Thank you. And for our listeners who aren't familiar with the acronym of SAMHSA, that is Substance Abuse and Mental Health Services Administration. Again, we're so good at alphabet soup, but so to explain a little bit of the alphabet soup, that's what SAMHSA is. And it really is a incredible and growing guide. So thank you for bringing that one up. And for our listeners, Dr. Dempsey, who want to learn more specifically about you and your work, you mentioned your book. Where do folks learn more about you?
Yeah, I have a website, KristinDempseyCounseling.com, and Kristin is spelled with two I's, opposed to other spellings of Kristin. And that's a great place to find me. But I'm also on social media. I'm on LinkedIn, and also have a professional Facebook page that people can find. And usually I'm posting various trainings that I'm doing or plan to do. Sometimes various aspects of my writing also show up there as well. Presentations or conferences that I'm at, and all great places to find out more about me.
Very cool. Thank you. This has been such an interesting and valuable hour. I really appreciate you coming on and sharing some of your expertise with us. It's been really helpful.
Great. Thank you, Beth. I've really enjoyed it.
You've just finished listening to another exclusive continuing ed podcast by Clearly Clinical. If you like what you just heard and you need continuing ed credits, please visit us at clearlyclinical.com to check out our one-year membership, where you'll have access to our growing library of continuing ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.